Okay, so for our last lesson in Think Like a Nurse, we're going to talk a little bit about cognitive bias and diagnostic error. And going through the readings on this, I found this quote, and I thought it was very pertinent still today. The phenomenal strides in every branch of scientific medicine have tended to overload it with detail, to winnow out the wheat from the chaff, and to prepare it into an easily digested shape for the tender stomachs of the first and second year students, taxes the resource of the most capable teachers. And that's from 1899. And for me, this is very pertinent for you as you're looking at these illness scripts and you're seeing where there's, hundreds of documents talking about each and every illness that exists. How can you pick out just the very most pertinent things so that you're focusing your learning and not just overwhelming yourself with trying to memorize every detail? It's just not possible to memorize everything, and let's try to use our cognitive skills to our advantage. What you've done in this course is learned a heuristic, and a heuristic is a method or set of rules for solving problems other than by an algorithm. So an algorithm differs from what we did, in that an algorithm will say, if this then that, if this then that, and take you down a decision tree. This is a little less scripted than an algorithm and a little more open for variability, which is good. So let's talk about decision making. So decision making can be fast or slow, and if it's fast, it's intuitive, and if it's slower, it's more analytical. There are theories that describe fast thinking, such as the Gestalt effect, inductive reasoning, deliberation without attention. There are heuristics and biases that go along with fast thinking. There are also theories that describe slower thinking, like hypothetico-deductive reasoning, robust decision-making, and Bayesian reasoning. All of these approaches are useful in healthcare from time to time and as appropriate, but they're not always appropriate all of the time. And probably if we can merge the two ways of thinking using our intuition with some analysis, we'll probably get the best effect for our patient. So first, let's take a look at the fast way of thinking, the intuitive way of thinking. Okay, the heuristic, it is heuristic. It's using a set of rules, but it's not an algorithm. The next thing you see here under cognitive awareness is that it's low cognitive awareness. And so that in itself could lead to diagnostic error. And so this is a potential pitfall. Automaticity, it's a high automaticity. So you reach your decision pretty quickly. Your rate's pretty fast. Your effort's pretty low because you're relying kind of on an instinct to come up with the correct answer or the way that you're going to answer this. The emotional component is high. We value our ability to focus or to make decisions based on our intuition, and we have a little bit of a self-esteem issue going along with this. So if we're wrong, we get upset about that. It's got low scientific rigor. It's not really based on evidence-based practice. It's more based on thinking about your experiences in the past and applying them to the future, which is a good thing. But if you're not aware of some of the pitfalls, it's not a good thing. And the intuitive fast system could be related to more errors. On the other hand, thinking about things systemically or analytically has high cognitive awareness, so you're less likely to make errors. But see, what you're trading off here is that, yeah, you're more cognitively aware, you're not as emotionally invested. It has high scientific rigor, and there are less errors, but what you lose is speed. And sometimes in healthcare, you need to be speedy. So this is why we kind of need a mix of both of these methods to come up with the best way to care for our patients. So just to reiterate about heuristics, they can be good. They're shortcuts, and it takes complex situations and makes them more manageable for us, and we become efficient. But they can be traps, and they can adversely affect our diagnostic decision. So it can lead to cognitive bias and it could lead to diagnostic error. Okay, so we're going to caution about that. So errors in medicine are not new. They've happened since medicine has been in existence. In the late 90s, there was a landmark Institute of Medicine report called To Err is Human. And what this report did was change the face of healthcare and how we need to think about providing healthcare. To Err is Human was one of the first publications that took away from healthcare this idea of just doing good. Just doing good, right? So trying hard enough isn't enough. So even if you make a mistake, if it's a life-threatening mistake or causes significant harm to a person, just saying to the person, well, I was really trying hard not to create an error, I'm sorry, isn't actually going to be enough to satisfy that person's family or that person if you've harmed them. And so what we needed to do was come up with some systems. Systems to prevent failure and prevent errors. Okay, and that's what we'll talk about a little bit today, a little bit about systems and how they prevent harm, and a little bit about the other side of that, how systems can actually cause errors. So we've been thinking about errors in terms of diagnostic decision making, but errors travel in all different ways throughout healthcare. It can be simple. It could be a medication error, wrong patient, wrong communication, all kinds of different types of errors. But we're going to focus mostly on using clinical reasoning to prevent errors in a systems approach. So we can categorize errors in a couple of ways, and these things should be pretty intuitive to you. If you have faulty knowledge, you're likely to make an error. If you haven't gathered data correctly or the correct data, you could have a cognitive error. If you are processing the information in a faulty way, you could create an error. And if you verify the information in a faulty way, you could create an error. So all of these things are rather intuitive, and it's actually more important to understand what these categories are than to give them a label, don't you think? One of the ways that you could have bias when you're looking at patients is called anchoring bias or premature closure. And this is a failure to consider other reasonable alternatives after a primary diagnosis is reached. And so the idea is as soon as you make the diagnosis, you stop thinking. And when that happens, a patient has an adverse outcome. And so let's say you had a patient and you decided that they had a PE or pulmonary embolism based on their signs and symptoms. And you treated them appropriately, you did diagnostic tests appropriately, you treated them appropriately, and but what's missing? So you treat them appropriately for a PE, right? But what if it changes? So what if instead of looking like a PE, what if all of a sudden they look like they have heart failure, congestive heart failure? The treatment's different, right? The way you diagnose it is different. But you haven't even considered it. So the patient is never going to get the correct treatment until something tips the scales and the patient has a severely adverse reaction, maybe severely short of breath, or another practitioner noticed they have crackles in their lungs or fluid building up in their lungs or something like that. So the anchoring bias is when you think, oh, it's a PE and I don't have to consider anything else, and you miss something very important. Confirmation bias, on the other hand, is when you think that you have a diagnosis and you're looking for confirming evidence, right? And so you're not necessarily recognizing and accepting the evidence that refutes it. Okay, so let's say you had a patient and they had sudden shortness of breath. It was very acute. But they didn't have, there was no leg swelling, there was no sedentary behavior. They had nothing that was pointing to a PE. But because the patient was saying it was sudden, you were locked in on PE, right? You were ignoring there was evidence to refute the PE instead of saying, oh, well, it's not. The patient's presenting with signs and symptoms that don't add up to PE, so let me look at something else. Does that make sense? Another bias that can happen is called the unpacking principle. In the unpacking principle, what's going on is that you're failing to elicit all of the relevant information when trying to make your differential diagnosis. And so then you miss things. You miss diagnosis. Another problem could be availability bias. And with availability bias, you treat things as if they're more important if they readily come to mind. So get rid of this one. So you judge things as being more likely. If they readily come to mind. So this is one of those things where if you see something over and over, you might just start to always think it's that type of thing. A classic example is that every nursing student who has taken care of a patient with Clostridium difficile or C. diff goes home thinking that they have C. diff as soon as they have an outbreak of a little bit of a stomach pain and diarrhea. Occasionally they actually do have C. diff, but not always. And that's that availability bias. They're looking for that, and that's what's very recent in their mind. The framing effect is another type of bias, and this is when you frame the patient's scenario and influence the way the patient is thought about. So in other words, what you're doing is reacting to a particular choice depending on whether it's presented as a loss or a gain, good or bad, etc. And so what you're doing is thinking about the patient with the PE example. What you will do is say that it's perhaps there's 70% chance of PE. That frames it in that way versus a 30% chance of no PE. Okay, so depending on which one of these tacks you take looking at this, it's going to influence your prioritization of the patient. Another type of bias you might see or run into is diagnosis momentum. We also call this chart lore. It's when diagnostic labels are attached to patients and the labels become stickier and stickier. So even in the lack of evidence, because we have once said that the patient has whatever diagnosis, they continue to have it even though it's not quite sticking. And yet another type of bias is visceral bias, and this is when you have countertransference of negative feelings towards a patient, and that might make you miss a diagnosis. Some of the common types of patients that might be a victim of visceral bias include patients maybe that are homeless. We have negative connotations about what being homeless means and whether or not that patient actually has problems or maybe even deserves health care. Those might be some ethical issues that come to your mind. Patients with chronic pain are sometimes seen in a negative light as maybe not really having pain but just wanting to get medication, even though they may have a real pain syndrome. Alcoholic patients, obese patients, non-compliant patients, all of these patients come with some kind of stereotype And all of these things involve some kind of judgment by the healthcare practitioner. So we're not just looking at these patients as individuals with healthcare problems, we're judging their situation, and that attaches some kind of a label to them, and it causes us not to see the full picture. One of the cases that I had when I was in the ER was this homeless guy who came in pretty frequently. He came in mostly to eat, but the ER obviously was not the most appropriate place to get a meal. And so the nurses and doctors didn't always take him seriously. Well, he kept coming in complaining of eye pain. It started off being about once a week, and then it turned into every day. And we would look in his eye, and there was nothing in his eye, and told him to go home, and it was fine. But then one day, when he came in, he had a rash coming from around his eye, and we realized that rash was consistent with shingles. And so this guy that we thought was just probably coming in malingering and trying to get food from the ER actually had a real problem, and we didn't see it right away. Now, we can argue that you don't see shingles in the prodromal period because there's no rash and there's nothing to see until the rash appears, and that can be weeks into the syndrome. But looking back, I think some bias probably occurred. So as you approach every patient, you should be thinking about cognitive bias and trying to avoid diagnostic error. So you want to cognitively think about. So when you're thinking about thinking, it's called metacognition. But this is what you'll be doing, thinking about thinking. What are the traps I might fall into? What else could this be? Is there anything that doesn't fit? Is there more than one thing going on? Is this a case where I can slow down? And so cases that you can slow down are usually the non-emergent cases, right? So once you deal with the life and death piece of a situation, you can usually slow down and think about cognitive bias and look a little more closely at the patient with an open eye, trying to find out what's going on. So I talked to you just now about some definitions of different types of bias. And of course, bias and error occur most likely in high-risk situations. So if you're at higher risk of creating an error, you're more likely to have an error, right? Makes sense? Here are some high-risk situations. So when you are in your healthcare career, you can think to these situations and tell yourself, oh, this is a high-risk situation. Let me slow down and be even more careful. So some of the things that can occur is that you receive report from a previous shift, and the report you receive creates a clinical picture for you, and that clinical picture could be framing the patient in a certain way or create some diagnosis momentum. And so just because the patient was diagnosed with, let's say, pneumonia, you weren't looking for heart failure, and so you didn't find it, right? So that's a high-risk situation. Whenever you're getting a report from the patient, you're going to take that report as a kind of like a suggestion. This is what we think's going on. And when you assess your patient and you talk to your patient, you're going to come up with your own image of what's going on and see, do they match or not? And if they don't match, make a phone call to your physician or provider so you can do something to help the patient further. Along the same lines is if the diagnosis was suggested to you by the patient or a nurse or another doctor. In that case, framing can also occur, or you could have premature closure. So maybe you didn't look at all of the options before you came to a conclusion. Did you accept the first diagnosis that came in? This is anchoring, and it could be premature closure. Did you consider other organ systems besides the obvious organ systems? Is this a patient I don't like for some reason? So maybe this is an affective bias. Could be a visceral bias as well. So some patients aren't nice to healthcare providers, and sometimes because when patients aren't nice to you, it's difficult to spend a lot of time with them doing a good assessment and collecting good information, but it's still very important, and the patient still deserves to get a full physical. So check your kind of your ego at the door and deal with that so you can care for your patient. You can ask yourself if you were interrupted or distracted while evaluating the patient. Every time you're interrupted, you basically have to start from the beginning so that you make sure you are looking at things very systematically and that you don't miss anything. Are you well rested? Did you feel fatigued? Do you feel fatigued at the moment? Are you cognitively overloaded? All of those things might be things that happen to you while you're in nursing school. So in nursing school in particular, with your studies requiring the amount of time that they do, so your reading for nursing school could be 6 to 8 hours of reading a day. 6 to 8 hours of reading, right? And so, and then if you're in school for 8 hours and you have to sleep for 8 hours, which of those things are you probably going to get rid of? You're probably going to decrease your sleep somewhere so that you can, have a little bit of a social life or something else going on. Actually, you might remove it from there too, but that'll come back and get you in a different way. But I digress. Nursing students do need to be aware of their fatigue and carry that idea of countering your fatigue and countering the riskiness of that with overvigilance. Make sure you're not stereotyping the patient and making sure you have effectively ruled out those must not miss diagnoses. So they would be the Tier 1E diagnosis. They're high risk, but unlikely. Okay, does that make sense? Okay, so talking about diagnostic error, there are some conditions, of course, that promote diagnostic error, and we need you to be aware of what those things are. It's uncertainty, high decision density, making decisions a lot of decisions that have a lot of weight on them. High cognitive load, are you overwhelmed with the amount of thinking and work and decision making that you have to make? Is it a new situation? Do you have time constraints? Are you under stress? Was it a handoff problem? With handoff problems, you may not have received all of the communication that you needed to receive in order to adequately care for the patient. In that case, you may not even know that you're missing something. There are problems with shift work and inability to sleep. Constant interruptions, and a constant interruption is defined as more than 10 per hour. And in nursing, you are living in a constantly interrupted state between call bells, phone calls, your peers needing help, helping others, getting help, helping patients, all kinds of things going on. This is a high-risk situation. And then violation-producing conditions. If you're over or underconfident, you're likely to make an error. And this is important for students, this over and underconfidence. It's this know what you don't know attitude that you need to develop. So know what you don't know. And to some degree, it's okay not to know things, right? You can't know everything. So using the tools that you've gotten through this course, you can identify the most important things that you need to know about situations rather than knowing every little bit. Okay? So this over and underconfidence is a problem. Lack of a safety culture is a problem. I'm seeing this more and more in healthcare. And so if people around you aren't as careful, you're likely not to be as careful. And that leads to what's called a normalization of deviance. And that is when you don't quite follow the rules every time, and because you got away with it that time, you do it again. And because the people around you are doing it, you do it even more. Okay, so it kind of leads you down a slippery slope. So healthcare is pretty complicated. And that's what this slide here is supposed to depict for you. This is an ICU patient, obviously. If you look at this, the IV pumps here, These are all the medications infusing into the patient, and that's one single patient. And along with all of those medications, they can all interact with each other. All of these different practitioners could be ordering different medications. The patient can receive medications from the pharmacy in different dosages right here, or concentrations. So they're both 20 milliequivalents, but one's in 100 milliliters and one's in 50 milliliters. And so that needs to be infused differently. That's a risk for error. This is a medication administration record, and this is where the nurse works from. So the doctor enters an order, and the pharmacy enters it on this medication administration record or one like it. And then, if I can make that bigger. And so you can see here, you have whatever, they have this medication, I can't quite read it, 10 milligrams daily. It's active and it's been available since that particular day. When you're giving your medications to your patients, you're going down this checklist and you're making sure you're giving every medication correctly. Right patient, right dose, right route, right concentration, right time, right documentation. But you're living in this chaotic world of many healthcare providers. Whoops, sorry about that. Many healthcare providers and many, many medications. So you're at risk for having errors. That means we have to create a system with double checks. And you'll be part of the nursing future, so you'll be part of the future of making that happen. Okay, so this chart is looking at the causes or etiology of diagnostic error. And you can see we've been talking about this cognitive error right here. And cognitive error is about a quarter of errors that occur in healthcare. But there's also systems errors, and that was what I was alluding to on the last slide. And this is when the system isn't set up to make safe decisions. And then you can have both cognitive and systems errors working together for about 46% of the time. A no-fault error occurs about 7% of the time, so it wasn't because you were having a cognitive error and it wasn't a system error, it was just happened for some reason that we're not sure of. And I'll point this out to you because if we can understand how the errors occur and in what ways, we can prevent them and have better outcomes. One of the ways that you can do this is make a checklist for your own care. And so every time you see a patient, you do your own complete medical history and a focused and purposeful physical assessment. So based on the patient's complaint. So it's focused. It's based on what the patient's complaining of. It's based on what you heard in the report. It's a purposeful physical assessment. So you're looking for key things, key findings to help drive your care. You generate an initial hypothesis using evidence-based medicine, and then you take a pause and time out yourself. Ask if you are comprehensive. Did you consider inherent flaws of heuristic thinking? Was your judgment affected by bias? Do you have to make a decision now or can you wait? And sometimes this is a matter of priority, so emergent or not. Emergent, urgent, or non-urgent might be some of the terminology that's used to describe that. The best way to go approach any patient is the worst case scenario. That's my favorite way to approach patient care, is thinking about what is the worst thing that could happen. And if I know what that worst thing is, then I can consider how to prevent it, right? So, prevent. And for me, a good example might be taking a report from a nurse and taking whatever their diagnosis might be. Let's say they have a diagnosis of pneumonia. And pneumonia is a lung infection. So when I walk into the room, I do my assessment for pneumonia. I look at the respiratory system and the cardiovascular system pretty closely first. And then after I get a sense of what that is, then I assess the rest of the body second. During this time, I'm talking to the patient and I'm finding out information, and that information I'm getting from the interview might drive further assessments. But I'm looking at that worst case scenario. The worst case in pneumonia is that they're not breathing, right? That's my worst case scenario. So I need to walk in there and look at them. Are they breathing? What's their work of breathing? Do they look blue or cyanotic? Are they using accessory muscles? Are they, using all of their chest wall muscles to breathe? Or do they look pretty relaxed, having a conversation, etc.? And you need to ask yourself, going back to this checklist, what are the don't miss items that you need to focus on? So once you do all of these things for every patient, this is actually maybe a 5 or 10 minute process for each patient. Should be one of the first things you do as you walk in and take care of, accept care for a day. Embark on your plan, but follow up. Expect changes. Expect for things to go wrong and have a plan on how you're going to counteract anything that could possibly go wrong. Okay, so let me tell you a story. In 1935, there was a military competition. There was Martin Douglas aircraft versus Boeing's Flying Fortress. The Flying Fortress was twice the range, 30% faster, 5 times the payload, and the first plane to have 4 engines. It took off from Wright Field in Dayton, Ohio as the lead. But the plane stalled at 300 feet. It crashed. It killed 2 men, including Captain Troyer Hill, who was Boeing's most experienced test pilot. So it doesn't make sense, right? This Boeing's Flying Fortress had twice the range. It was faster. It had 5 times the payload. It had 4 engines. There was no reason for this plane to go down. What happened? Okay, so let's take a look inside this Flying Fortress. You have a place for the pilot and the co-pilot, and you have all of these mechanisms going on to control the airplane, right? But what happened was, in this case, the pilot forgot to release the tail elevators. He forgot. Not, cognitive error. And because of this cognitive error, he and his co-pilot lost their lives. It was quoted as saying, "It's just too much airplane for one man to fly." If we look back to that slide of the ICU nurse with all of the IV drips and all of the healthcare providers around the patient, is that just too much healthcare for one nurse to man? That's a question. So the problem that was encountered in the Flying Fortress was that was a very complex airplane. We had some complexity issues. The solution, this is great, the solution was not more training. It was not redesigning the airplane. It was creating a checklist. Checklists save lives. Okay, so then the B-17 and its checklist flew the next 1.8 million miles, 1.8 million miles without an accident. The military obtained over 13,000, and the B-17 was the workhorse of the Allied Air Force in World War II. So let's think about this ICU situation we were talking about. It was a complex situation. Creating a checklist will reduce cognitive strain and reduce cognitive bias, improving outcomes.